Order. Simon Clark to move the motion.
Thank you, Ms McVeigh, and it's a pleasure to serve under your chairmanship today. I beg to move that this House has considered NHS funding for the treatment of Pectus deformity. I also beg to move that this House has considered e-petition 329161 on the same subject, which I'm delighted to say has been signed by over 6,000 people, including 183 from Middlesbrough South and East Cleveland. I thank everyone who's given their time to sign that petition, as well as its organisers. The lack of treatment of Pectus Excavatum on the NHS is an issue by which I've been deeply moved and where I'm determined that we should deliver lasting change. The situation as it stands amounts to an injustice for a young girl living in my constituency and many more like her across the country. It is, however, a matter that can be solved, and simply. The solution wouldn't be particularly expensive, it isn't controversial, and I sincerely hope this is a matter which can attract ministerial support. It was around 6 weeks ago that I was first contacted by the parents of Autumn Bradley, a 14-year-old girl from Gisborough who suffers from Pectus Excavatum. Caused by an overgrowth of cartilage, this condition means that as she grows, her breastbone is being pushed inwards towards her spine. In Autumn's case, this inward growth has advanced to the point at which her sternum is now just 25 millimetres from meeting her spine. For many people living with less severe forms of Pectus, its impact is predominantly psychological. However, for Autumn, this condition has been nothing short of life-changing. Her parents have watched as the physical condition of their once active, energetic daughter has deteriorated beyond recognition. Growing up, she had excelled at athletics, competing at county level, but today, Autumn struggles to blow up her balloon. Complications of the condition have led to numerous hospitalisations. Her school attendance and academic performance are being increasingly affected. It now causes her pain even to hiccup. Treatment for this condition is effective, routine and widely available across the developed world. It is available free of charge on the NHS in Scotland, Wales and Northern Ireland. Since early 2019, however, it has not been available to patients in England. Because around 90% of surgeries to treat Pectus are deemed to be cosmetic, last year a decision was made that treatment would no longer be funded by NHS England. Ruling out treatment for psychological reasons is a debatable proposition in its own right, but it is not inherently unreasonable. What is unreasonable is that the 2019 NHS policy document is clear that treatment for Pectus will not be available, irrespective of the seriousness of the symptoms. As a result, Autumn's surgeon, Mr. Dunning, has found it absolutely impossible to make the case for treatment on an exceptional basis, even in cases where the physical impact of Pectus is as devastating as it is for Autumn. Mr. Dunning is based at the wonderful James Cook University Hospital in my constituency. He estimates that as a result of the situation, around 50 patients a year in England, overwhelmingly teenagers, are being left suffering life-limiting symptoms that could easily be fixed. These symptoms include shortness of breath, heart rhythm disturbances, and even episodes of collapse. Mr. Dunning spoke recently on BBC Radio Tees about how the current NHS policies affected Autumn in particular, and he said, "I believe it is a complete disaster and a mistake that we cannot turn this around. We found it impossible to change it. We're looking for anything we possibly can to try and get this poor, short of breath person an operation." He added, "I couldn't be more confident in being able to fix this poor girl with an operation." If we were allowed to carry out the procedure, Mr. Dunning says that Autumn would be in hospital for 4 days, with 3 weeks to recover at home, but after that she would be a new person for the rest of her life. The average cost of surgery to correct Pectus deformity is between £7,000 and £16,000. Treating 50 such patients a year would therefore cost less than £1 million, which in the context of the wider NHS budget is a minute sum of money. Mr. Dunning's passion for helping patients like Autumn has led him to campaign extensively on this issue and to dedicate a significant amount of time to supporting those affected. His commitment to her care and those of her fellow Pectus sufferers is beyond all praise, and he represents the very best of our National Health Service. I'm equally grateful to BBC Tees and to campaigning newspapers like the Teesside Gazette and the Northern Echo for helping to raise the profile of this issue. What then has gone wrong with the NHS commissioning process? That process, which began in 2015, resulted in a 2018 literature review, which considered only 6 papers, all of which focused on the psychological benefits of surgery, and resulted in a judgment that, and I quote, "The evidence that was found is not sufficient to conclude that the physical, psychological and behavioural benefits of a surgical treatment of pectus deformity are sufficient to justify its use. This is despite the final policy document acknowledging, and again I quote, "The impact of pectus deformity can vary substantially, ranging from mild and symptomless to severe and impacting on both lung and heart function." During the consultation process, the Society for Cardiothoracic Surgery submitted 9 additional papers, which they felt contained important evidence that should be considered. All 9 were rejected, some for what seemed dubious reasons. One study of 168 patients from the United States was rejected on the grounds that a single surgeon performed all the operations. Yet most of the papers included in the 2018 review are single-centre studies, and one included paper is explicitly a single surgeon case series. A 2015 NHS England policy document stated, with reference to previous papers from 2007 and 2010, leading US centres report inclusion criteria for surgery as severe pectus excavatum that fulfills 2 or more of the following: CT index greater than 3.25, evidence of cardiac or pulmonary compression on CT or echocardiogram, mitral valve prolapse, arrhythmia, you can tell I'm not a surgeon, or restrictive lung disease. For reasons which are unclear, these impacts were not considered by the 2018 literature review, and I find it concerning the submission wasn't corrected, even when highlighted by thoracic surgeons. The case for allowing surgery for more extreme cases of pectus seems clear, based on the expert reviews I've seen. These show measurable improvements in cardiopulmonary function in patients with a Haller index between 4.5 and 5, the Haller index being used to describe the severity of an individual's pectus deformity. I will outline these below, and it's worth remembering here that Autumn's condition is far more severe, with a Haller index of 9.7. A 2011 French study of 120 severely affected patients with a mean Haller index of 4.5 showed that surgery delivered sharply improved heart function. Prior to surgery, the maximum rate of oxygen consumption of patients was just 77% of their age-predicted maximum. 1 year after surgery, this had increased to 87% of their age-based prediction. A 2013 Danish study with 49 patients of mean Haller index 4.9 showed that patients with pectus had a 20% lower cardiac index than healthy control patients at the same age prior to surgery. 3 years after surgery, the cardiac index of treated patients had normalised to be similar to the controls. I am clear that the NHS commissioning process has failed on this occasion. It has excluded crucial evidence about the benefits of pectus surgery for those presenting severe physical symptoms, and it is written too prescriptively to allow any discretion for individual funding requests. Autumn has already been rejected for an IFR twice, despite her life being made an increasing misery by this condition. And I defy anyone to explain how, in severe cases like Autumn's, a normal, healthy life is going to be possible without surgical correction of the deformity. I want to pay great tribute to Autumn today and to her mum Sarah. Until now, Autumn has been known publicly as Katie to protect her anonymity. But ahead of this debate, she has bravely waived that anonymity for the first time. She has asked me to share with the House, in her own words, how her life has been affected by this condition. And she said the following: "For as long as I remember, I've had Pectus Excavatum. When I was younger, I embraced it as it made me unique. It didn't affect me massively. I loved sports, I ran and did long jump for the county competitively, I surfed, climbed mountains, played football with friends, went to scouts and much more. I spent free time caring for animals in a pet rescue. However, as the years went on, my pectus has got progressively worse. The dent deepened, I began to suffer with my health. Every cold I had went on my chest and needed antibiotics and steroids, and I often ended up in hospital. I've begun to miss massive amounts of school and all the things I love. Fast forward to now, I can't do any sports, or the clubs I loved have gone. I feel so tired constantly. My ribs and back are in so much pain. I take painkillers all the time, but it still hurts. I can't breathe. I can't take a deep breath. It feels restricted and like my chest is being crushed, and I can feel my sternum touching my spine. Climbing stairs leaves me breathless. I don't even attend school now. My dream was to be an athlete or a nurse. My chance of the first dream is gone. I'm so worried about what the future holds for me, as my school grades will start to suffer. All I'm asking is that you reconsider the decision not to offer pectus surgery, as it would give not only me, but lots of teens like me, a chance of a normal life like those who are not born with this condition. So what ought to be done? I'm very grateful to the Minister for his time and consideration of the issue in the days leading up to this debate. He is an excellent Minister, and I'm all the more grateful given the many other demands on his time given the wider national situation. Likewise, I am thoroughly appreciative of the time given to me a fortnight ago by our Right Honourable friend, the Secretary of State for Health. He could not have been more attentive, and he joined myself and my colleague from Bury South in a really good discussion about what we might do to try and move this situation forward. I know that last week he raised the matter personally with NHS Chief Executive Simon Stevens. My central request is that the NHS should be asked to reconsider their wider policy on this issue as a matter of urgency. While such a review is conducted, and in the interim, it would be fantastic if a holding situation could be established by which there is a facility for surgeons to appear in person to discuss the evidence for Pectus surgery in the most severe individual cases, effectively a kind of extraordinary carve-out from the wider policy. This would reflect a suggestion made by 4 of the 5 stakeholders during the commissioning process. It would make sense to allow this subset of severe patients to be identified so that selected centres can perform the operation on the NHS and report their findings in a registry. This commissioning through evaluation would allow a continuation of surgery for this small subgroup, while also monitoring the impact of the surgery and providing valuable and new data to inform a wider policy review. This would offer both a short and a medium-term solution to this issue because no one expects a miracle solution overnight. The process of NHS commissioning is rightly complex and is rightly independent. Nonetheless, we should try and kickstart that process today. I'll be very happy to meet further with the Minister or his officials on this issue. But it is, I think, the case that the current policy on Pectus Excavatum is not right and should not continue. I agree with Autumn, I agree with her parents, I agree with experts in the field like Mr. Dunning. There are cases where Pectus surgery is anything but an aesthetic choice. For a small group of young people in this country, it is the only route to anything resembling a normal life, and we should restore this treatment free at the point of need at the earliest opportunity.
The question is that this House considered NHS funding for treatment of pectus deformity. Christian Wakeford.
Thank you, Ms. Day, and it's a pleasure to be serving under your chairmanship. I'd like to start by thanking my honourable friend, the member for Middlesbrough South and Cleveland, for bringing this very important topic forward for debate. Similar to my honourable friend, I too had a case of a particular constituent, a 17-year-old girl who, when we refer to the Haller index, a index value of 3.1 would normally be the threshold to require surgery. My constituent had a measurement of 9.6 and was basically told that chest capacity was similar to that of someone over 100 years of age. So her chest capacity was so poor she couldn't bend down to pick up the shopping, she couldn't go upstairs without being out of breath. And as a 17-year-old girl with her entire future ahead of her, that cannot be right. So it is a disappointment that the previous commissioning report suggested that Pectus Excavatum would not be covered under the NHS. In regards to those more cosmetic procedures, I'm fully supportive of those remaining not to be covered. However, for that small cohort, and we do estimate it is within the region of fewer than 50, this is a life-changing and potentially life-saving procedure, especially considering that the cost is so small in comparison to most treatments. I'd like to pay tribute to Dr. Joel Dunning, which my honourable friend referred to as well. My constituent, purely by chance, came across him, and it was during the great work he was doing during the first lockdown, because obviously elective procedures were cancelled, so he volunteered elsewhere in the NHS, actually as a nurse. And it was as my constituent was in the hospital seeking advice and treatment, he overheard the conversation as to what was going on, and being an expert in the field, stepped forward, stepped up, and came to the field and actually made this representation. And it is now that my constituent has had the surgery. Now she and her family have been in a very fortunate position that they could afford to have that surgery. Now granted, they should never have been in that position, but already her chest capacity has improved dramatically, and she is able to breathe, to walk, without being out of bed. I mean, granted, she's still in a lot of pain and on morphine, but she is already feeling the improvements that she should have as any basic rights. Considering this is such a small cohort, the previous comments were we should potentially look at doing further studies and recommissioning, but because it's such a small cohort and there's so few experts in the field, it is very difficult to actually do individual studies in this. So I think the comment my honourable friend made in regards to having almost a panel where the surgeon could step forward and make representation as to what he thinks is necessary and what is the most likely to improve the lives of these young women is the best approach. I will keep these comments extremely brief because I obviously do want to hear from the Minister in regards to the great work that he's doing in regards to this and hopefully more to offer. But again, just want to put on record my thanks to both my constituents' family, to Dr. Joel Dunning, and of course my right honourable friend, the Health Secretary. This thing is in the middle of a second lockdown to actually discuss this very important topic for this small cohort of constituents. Thank you.
Minister.
Thank you very much, Ms McVeigh, and a pleasure to serve under your chairmanship in here. I'm grateful to my honourable friend for bringing to the attention of this House the issue around funding for the treatment of Pectus deformity and the impact that has on people with that condition. And I also pay tribute to my honourable friend, the member for Bury South, who in what I think is a week or two shy of being in this House for a year, has already made a huge impact on behalf of his constituents in this place. And I hope that through him I can wish his constituent well and wish her a full and speedy recovery from her surgery. Before I discuss the particular case and issue, Ms McVeigh, I want to firstly place on record my thanks and gratitude to the hard work of NHS staff across the country who, as always, have gone above and beyond in supporting all of us during this pandemic. We remain indebted to them for their service. I also want to be clear that this government has and always will support our NHS, providing it with the finance and resources it needs to continue to provide high quality, life-changing care. And support this, as honourable members will know, in the NHS long-term plan, we committed to and then legislated for increasing investment in the NHS by 33.9 billion in cash terms by 2023 to 2024. Now, Ms McVeigh, a fundamental principle of the NHS is that for people who live in the UK, treatment is free at the point of need, regardless of an individual's ability to pay. That's the basis on which our NHS is built. And at the same time, however, of course, CCGs have a duty to commission responsibly and to use the funding they do have to deliver the best service they can to meet the needs of the overall local population. And as such, there will be some treatments or services that aren't routinely commissioned locally, and these decisions can be both difficult but must be subject to rigorous assessment. Surgery for those patients with severe physical complications arising, in this case from Pectus Excavatum, is one such area, as my honourable friend set out. NHS England, an improvement which, with your permission, I'll refer to NHS EI throughout this speech for brevity, recognised that a small number of patients might benefit more from surgery, and as he set out, have explored this area in depth. And he mentioned in August 2018, NHS EI launched a clinical commissioning group policy consultation for surgery for Pectus deformity and sought feedback regarding that proposition for surgery for Pectus deformities for all ages. Now, in developing their policy proposition, NHS EI commissioned 2 evidence reviews to ensure evidence for both surgical outcomes and psychological benefits were considered. Now, that review considered whether scientific research has shown the treatment to be of benefit to patients and whether its use represents the best use of NHS resources. And in that context, I hear very clearly the points made by my honourable friend about, in his view, the limitations imposed on that by the nature of the process and the evidence base. Now, Ms McVeigh, after careful consideration, as he has set out, the findings of the NHS EI evidence review concluded that for the surgical correction of Pectus deformities, that there was not sufficient evidence to routinely commission that intervention. As I say, my honourable friend has set out very clearly his counterpoint to that position. The study published in February of last year noted that in most cases, while surgery can correct the chest wall deformity, surgical intervention does not always take place. This is because the majority of people experience only mild physical or psychological symptoms associated with having a pectus deformity, according to the evidence put forward by that review. Now, I also understand that that review also discovered areas where further evidence was required. And NHS have been working with clinicians and the National Institute for Health Research to further build this evidence to support commissioning decisions. I also want to be clear that whilst based on the existing evidence, whilst, as I say, based on the current evidence base, surgery for this condition isn't currently routinely commissioned at the moment, but this does not mean that patients cannot access it if it is deemed clinically necessary in particular circumstances, as my honourable friend, the member for Bury South, was able to set out in the case of his constituent. And there are processes in place to ensure that if deemed clinically appropriate, patients can still access a treatment even if it is not routinely commissioned by the individual CCG. The process being, as he set out, the individual funding request, or IFR, which can be an alternative route. Although, of course, as my honourable friend, the member for Middlesbrough South and East Cleveland, set out in the case of Autumn, clearly this has not worked for her. Turning to her particular circumstances and my honourable friend's constituent's case, I am incredibly sympathetic to the case that my honourable friend raises and understand both his concerns and the need for pace in finding a solution to help Autumn. And I would at this point, if I may, Miss McVeigh, pay tribute to my honourable friend, the member for Middlesbrough South and East Cleveland. He is a doughty fighter on behalf of his constituents, as we've seen in this case. We are incredibly lucky in this House, as are his constituents, to have him representing them. And I would say that he has made very good use of what I hope is a very short period of freedom from ministerial office, therefore allowing him the ability to speak in debates such as this. And he has used that freedom powerfully, once again, on behalf of his constituents, in this case, in bringing forward Autumn's case, this House. And I hope that his constituents will not take it remiss if I say that while that I know has been incredibly useful to them as a powerful advocate, as he always is, I hope that his freedom will be short-lived and he will return to the bonds of ministerial office soon, because he was a fabulous minister while he was fulfilling his various roles. And I also want to say, if I may, I'll put on the record, if I may, Miss McVeigh, my recognition and pay tribute to the courage that Autumn and her mother Sarah have shown. It takes incredible bravery and incredible courage to speak out, and as she has done through my honourable friend, to speak out under her own name and her family's and her mother's name. I think that that shows a courage which it is very rare to see in any walk of life and in anyone, and I think it deserves recognition by this House, and I hope that he will pass on to her my words in respect of that. She is an incredibly brave young lady. Turning to the points he makes, the specifics of them. While he will know, and it's only right that I would caution him, that decisions and the response on this are, of course, sit with NHS EI and are not within my gift as a minister to give. He makes an incredibly powerful case. So what I will say to him is I am very happy to convey very clearly, as my Right Honourable Friend the Secretary of State has done, to NHS England and Improvement, to the Chief Executive, Sir Simon Stevens, his and his constituents' very clear request that this position be reviewed once again with additional evidence considered. And I will also put to them his very sensible, or what seems to me his very sensible suggestion of an approach in the short term and then in the longer term. As I say, I have to be honest with him, I cannot commit what the NHS response will be, because quite rightly they are independent and they will make those decisions themselves. But what I can promise him is I will put his case to them very clearly. I can also reassure him I am, of course, always delighted to meet my honourable friend, and if he feels that would be useful, I'm very, very happy to meet him again. We may do it in the next few weeks while he enjoys a few more weeks of freedom from the red boxes. But I'm very, very happy to do that for him, because this is an incredibly moving case. He has put the case in very human, very moving terms, but I suspect that, if I may put it this way, Autumn, in a sense, represents probably many more cases, as my honourable friend the member for Bury South has set out, who may not have felt able to come forward, who may not be publicly known, but there are others who will be in her position, who will be listening to what he's said. And while I pay tribute to him, as always, for his eloquence, I have to say I'm afraid that while he put his case very powerfully, Autumn's words put it even more powerfully to this House. And there will be people listening to what she said and identifying with that and feeling the same things. So I'm always happy to meet him if he feels that would be helpful. And to conclude, if I may, Miss McVeigh, I will reassure my honourable friends that we will continue to work with clinicians and researchers to build the evidence base and understanding of this condition to support future commissioning decisions, but also hopefully to, within the confines of the clinical evidence base and decisions by NHSEI, to be able to better help people like Autumn in the future. I'm grateful to the House, Ms McVeigh.
The question is that this House considered NHS funding for treatment of Pectus deformity. As many are of that opinion, say aye. Aye. Of the contrary, no. I think the ayes have it, the ayes have it. Order, order. The sitting is suspended till 2:30.